January. Welcome to our January quarterly meeting for OPQIC and the Oklahoma Maternal Health Task Force. Um, we'll look at our agenda here. Oh, first of all, you got the message just now about recording. If you're okay with that, we will move on. Just wanted to make sure you all rename yourself on Zoom or type your name into the chat box if we cannot tell who you are by your name, how it's currently spelled out as your participant. Thank you all. Or if we don't know who you are, go ahead and say your name and where you're from. Here is our agenda tonight. So I am going to go ahead and go on to the next slide with our Oklahoma State Department of Health and um, updates. I think everybody probably knows that Joyce Marshall retired. So Lori Essery is here. She has taken on Joyce's Division of Maternal Child Health. They have been folded into Family Support and Prevention Services. So Lori is here tonight to give us updates for the Oklahoma State Department of Health.
Good evening, everyone. As Barbara said, I am taking on Joyce's role and big shoes to fill, and so a lot a lot happening. Learning a lot, just delving in. It's been a busy January. Let's just put it that way. So I'll just kind of hit some highlights as the merger is happening. We're kind of really figuring each other out and learning each other as we come together as a team. But I'm really excited. I think it's going to be a really great opportunity. We do so many things that are similar. It's going to create this amazing continuum of care. So very excited about that. Some really positive things right now. We received the Erase grant, excuse me, which will have the focus on maternal mortality. So we're really excited about that. And the Maternal Innovation Grant just renewed as well. So those are good news, good positives for our service area and for women and children in Oklahoma. We have a few challenges right now. I think most folks are aware, anyone working in state government, of the governor's mandate to return everyone back to office. And we have been, most of the State Department of Health, because of space issues, we've been on a hybrid telework schedule. So we are really trying to get space organized right now. We're looking at leasing additional space. I'm bringing desk in. We're trying to get everyone organized and back in office by February 3rd. We're trying to get creative with our folks who work out of the metropolitan area and getting them housed at local health departments. We have wonderful staff. We want to keep them. So we're really trying to be creative in our solutions. And I'm sure a few of you are maybe going through some things, but we're also excited about as office together. We'll have more synergy. I think it will improve communication. So even though it's a little difficult, we're all trying to be very positive and see the really positive and bright side of things as well. Related to legislative updates, I don't really have any right now because we are just as we know the legislative session will kick off the 3rd as bills are finalizing and coming in. One of the things OSDH does is our policy area, they do a great job putting together all the bills that have impact on the health and well-being of Oklahomans. We review those. We haven't gotten those assignments yet, so I haven't really looked in depthly at any of those bills yet as they're being organized and put together. So we will stay on top of that. We always engage and really try to let everyone know what's happening legislatively, especially anything affecting mothers, children, and families in the state of Oklahoma. So I'll have more information to share, but and our priority legislative areas of Oklahoma State Department of Health is also still being kind of put in place as these bills emerge. So I apologize. I just don't have a lot of information yet to share regarding those. Um, I think that's really all I have. Jill, did I miss anything really big? Keep me honest.
No, I just wanted to point out that Lori, in case you don't know, is over the other, I mean, in
Yeah.
her current area, is over the home visiting programs and also the prenatal resource navigators. So you've heard from Kelly. Some of you that were on that meeting have heard from Kelly during this meeting about some of those resources, but just so you kind of put a face with a name and understand that Lori is already over those areas. Like she said, we will be working more closely together on lots of projects. So,
And just real quick, the last thing I'll say is there's been a real push at the federal level to align a lot of the work of McPhee, maternal infant earlyhood child home visiting, which is again under FSPS with Title V. So we're kind of really excited about some of what's coming out, federally along those lines. So hopefully I'll have more to share at future meetings regarding that effort. So that's it. Thank you very much.
Thank you so much, Lori. And yes, we've enjoyed getting to know Lori and over these next months and years, I'm sure we will get to know you well. So thanks so much for being here and welcome to
Barbara. Oh, I'm sorry. I have one
Go
more
ahead.
thing I wanted to share, and I'm going to post this in the chat. I apologize.
That's okay.
I am posting the link to our Choosing Childbirth page. I don't think
Okay.
everyone knows that the 13 awardees of Choosing Childbirth, they are public. They are on our website. And I've heard from a couple of people, they were asking me and they were surprised to know that. So I wanted everyone to know that that is very public knowledge. We want everyone to have that information. We're really gearing up. We're going to do a community of practice with our Choosing Childbirth awardees and really kind of help them use each other's resources and leverage each other's resources and bring in other folks across the state that are happening. But again, you can go to that site and look at the awardees and also the proposed coverage areas for each of them as well. So thank you, Barbara.
Thank you, Lori. Appreciate your adding that information. So welcome. Also, from the Oklahoma State Department of Health, we wanted to provide an update on the newborn screening program. Sherry Arsenault has been working with all of our birthing hospitals and wanted to share some information now that we have preliminary data for 2024 on the different types of conditions that were screened positive for in Oklahoma. So Sherry, I'll let you share that information with us.
All right. Good evening, everyone. I think it's always very gratifying, hopefully to you guys as collectors, to see some of the really concrete results of your diligence. And I have written out the whole long names of some of these acronyms because I barely know some of them, and I know most of you have never heard of, per se, medium chain acyl-CoA dehydrogenase deficiency. It's much easier to say MCAD, but it is helpful to see. And so these babies were all diagnosed via blood spot collected in most of your facilities in 2024. They all received confirmatory testing. As a reminder, you guys know the screen itself is not a diagnostic tool, but a screen. And so these babies all underwent confirmatory testing and are now connected to the appropriate specialist and receiving care and thriving in the state of Oklahoma because of the work that you did on a baby that looked 100% well to you. So it's, I'd like to point out that 4 of these disorders, MCAD, Pompe, VLCAD, CAH, are 4 on the screen that are indeed time critical disorders. So these are babies who would have gone home at day 1.5, 2 days of life looking beautiful, and within a week would have had a dramatic change in their situation and may or may not have gotten to the appropriate care without that diagnosis. So kudos, good work. That's a lot of babies that we're identifying. So I want to thank you for that. And then from an education point of view, Barbara referenced that I did get to go visit every birthing hospital last year, which was really a delight for me. And I see a lot of your names on the screen, and that always makes me remember popping out to all of your spots. And I am going to come see many, many of you again this year for the purpose of just continuing to troubleshoot areas where we can fine tune processes to help you guys be the best that you can be. So we'll be in touch about that. But I focused education last year kind of at the point of screening, like the blood spot, the CCHD, the hearing, what are we doing at the moment? And now I'm getting to expand education a little bit to after the blood spot. So I've been to 2 different large pediatric groups to be able to talk to PCP staff, the nurses who are talking to families, letting them know about out of range screens. So getting to talk with staff who are dealing with families after a screen is positive and helping them get the resources they need. And I've also had the privilege of visiting with 2 different midwife groups. And that's been other areas when I've been able to make some strides and getting newborn screening education out there. And I'm hoping we're making baby steps right now to get into the pre-blood spot, pre-screen space. So we can make some inroads into that prenatal space so that when moms get to the hospital or to their midwife, they already know what newborn screening is. So they're not hearing about it from you for the first time. So those are some of my goals and hopes for the next year. And then the last thing I want to share with you, you'll continue to hear from me about a variety of things. And one of the things that you'll hear from me in the next couple of weeks, maybe 2 to 3 weeks, is just some suggestions for you in implementing. There are some new, American Academy of Pediatrics has updated its recommendations for CCHD screening, including a new recommended algorithm that is a little bit simpler than what is recommended in the past. So I'm looking at some getting an email out to all of you in leadership in the next couple of weeks. So you can keep your eye out for that. But they have published their updated position. And so we want to keep up with that. And that is all I have to share tonight. Thank you, guys.
Thank you so much, Sherry. I calculated 107 infants in there. So I think it's so important what we do. And she's really been working with the birthing hospitals to ensure we do adequate collection and timely transportation to the public health lab. Those things are so important. They do a lot of follow-up in the newborn screening program there, and this is so important. We appreciate the work that you all do. So we're excited to be partnering with them and to have Sherry help us. And we did have a social media post about it. And if you have any questions or want to talk to Sherry or want to find out more, we have the information on our website, and it's on the Oklahoma State Department of Health website as well. Sherry, you might put your email in the chat so they could
get in touch with
you if they need you. So
I should have emphasized that those are preliminary numbers for 2024. Some babies are still in their diagnostic phase, so that's not a final number, but it's too important not to share it, even though it's a little bit early to call it complete, but I wanted you guys to see that.
We'll share with you the final number when we have it. So thank you. Thank you so much, Sherry. Does anyone have any questions for Sherry? Thank you. Susan gave you a shout out for doing a great job educating the C1 nurses. Our next presenter, we have Falaki Adedeji, who is here from the Oklahoma Healthcare Authority. She is their Chief Quality Officer and is going to be providing us updates from OHCA. Thank you, Falaki.
You guys are on mute.
Lucky you're on mute.
You would think by now I would have a hang of that, but it happens all the time. So, anyway, I was just saying that I said hello to everyone, and that I only have one update, and that's that today at 1 p.m. we had our Senate budget hearing. Um, that's my update. But then I will be talking to you about something else that Barbara had asked me to talk about. So, Barbara, are you going to move the slides for me? Oh, thank you. So I don't know how many of you have heard about the Transforming Maternal Health model, but I'm going to be talking to us about it today. It's a grant that CMS put out towards the end of last year, no, 2 years ago in 2023. And they had said they were going to fund up to 15 states to implement the model in their states. And so at OHCA, we had a conversation about it. We talked to leadership, asked if we needed to apply, and the consensus early 2024 was that we should apply for it. And so recently, just before the holidays, we got a notification from CMS that we had actually been awarded the grant. And so I'm going to be presenting on the grant today and talking through what it is, how Oklahoma is thinking about implementing it. Several of you are on work groups with us when we were applying for the grant, so a lot of this information may not be new to you. But for those of you that are just learning about it, I'm happy to also connect outside of this space if you have more questions. Next slide, please. Next slide. So, like I said, a while back, CMS said, we want to improve maternal health outcomes in, around the country. And they had said, we would pick 15 states, but they had also predefined the goals of the model for us. And so up here, I just threw out some of the goals that they have for implementing this model. I mean, it really does revolve around just making sure that, our maternal health outcomes are better. It's a 10-year grant, and we'll talk about that some more. But these are some of the things that they would like to see at the end of the 10 years. They're wanting us to reduce low birth weight, the rate of low birth weight in France. They want us to be able to survey the pregnant moms, and all of these are Medicaid moms. That's something I should put out there. So it's Medicaid focused. They want us to be able to survey the pregnant moms for their experience pre and post delivery. And they had some other goals around C-section and reducing the incidence of maternal morbidity. Next slide, please. Oh, I'm sure this is really hard for everyone to see, but when they put out the model, they had an idea of what they wanted to see states do. And one of the things that they wanted states to do to kind of bridge the access issue was to begin to look at other non-traditional provider types. And so they really call out doulas and midwives, as well as perinatal community health workers. And of course, the providers have the OBGYNs and the family docs who see pregnant moms also have a part to play in this. And so they put this out as, for the longest time, this was all we had to go off of. And it really just talks about surrounding the mom with all of those provider types and having them coordinate the care of the mom, depending on, where the mom is at in their journey. So this is an example of a pregnant mom who's on Medicaid, who's about 25 years old, but also has a chronic condition as well as social drivers of health needs. And so the way they put the model out was, well, one of the things they called out in the model was having the community health workers kind of meet with the mom and help connect them to services, but also having a midwife who could make sure that kind of having a midwife who could work together with a provider or an OBGYN to make sure that the mother's clinical health is taken care of, and then have the doula also come along for emotional support and just advocacy and things of that nature that doulas bring to the table. Next slide, please. And so, like I said, just before Christmas, we found out that let me back up a little bit. So we had to we submitted our proposal in September of 2024. We had 2 rounds of negotiations with CMS. We didn't even know we were negotiating with them. They would just send us these documents and ask us more questions or ask us to clarify certain things. And so we went back and forth for about 2 months. And then just before Christmas, we got an email from them saying that Oklahoma was one of the states that had been selected. And so up here, you see the list of our sister states that would be participating in this model alongside with Oklahoma. Most states have their budget, but when CMS put out the notice of funding, they had said that we could receive up to $17 million over the life cycle of the project. And I think for us, when we submitted our budget, I think we were right around $16.9 million. The model itself, is a 10-year like it's going to run for 10 years. The first 3 years, and it started January of this year. So we've actually started meeting with CMS. So the first 3 years would be planning and implementation years, to where we have CMS bring in technical assistance around some of the things that they want us to develop and some of the things they want to see during implementation. And then from year 4 to year 10 would be the years where we implement the things that, we said we were going to do. Next slide, please. So the model itself has 3 pillars, and each of those pillars have several elements. If you're interested, I'll also drop my email in the chat. I can email you the documents, the proposal that we wrote, the negotiation documents, as well as the pillars and some of the other materials if you're interested. So one of the pillars is really making the access issue better. So we all know that we have challenges, we have maternity deserts, we have areas across the state where we don't have enough providers to be able to meet the needs. And so CMS really called that out to say, we want you to begin to look at other ways of bridging the access gaps that you have, and what workforce do you have available in the state that you can bring to the table and actually begin to work with, so that you can provide some kind of access in those areas where you currently have a gap. The other pillar that they kind of called out has to do with what OPQIC does, which is the implementation of the AIM safety bundles, as well as, they really called out leaning on our perinatal collaboratives to help us with this piece of it, the quality improvement and the patient safety piece of it. And then there's a whole person care pillar that actually focuses on clinics and practices that, see pregnant moms and just wanting to increase screenings. So not just perinatal mood disorders, but also social drivers of health risk assessments. Next slide, please. And so when we were writing the proposal, and we didn't walk in a silo, like we didn't work by ourselves to come up with the design. We worked with several partners across state agencies, as well as external partners outside of state agencies, to kind of decide what needed to be done. At that time, Joyce was still with us, so Joyce sat on the work group alongside with Jill and some other folks from the health department. But we also had GKFF, who's the George Kaiser Family Foundation. They had a representative on that team, and we kind of decided that $17 million wasn't a lot to cover the whole state, because CMS had proposed 2 types of implementation. So you could cover the whole state, or you could isolate a region where you felt like you had higher levels of disparities. Maybe you had more births. They had a few criteria that we could use to select. And so we felt like a sub-state implementation would be better for us as a state. It would also allow us to stretch those dollars. And so some of the things that we looked at before we decided on the counties that would be the test counties where, are they rural? Are they underserved? Do they have tribal presence? We also looked at just areas where we had more Medicaid births happening across the state. So that was one of the things that we factored in. And we also looked at, where our MCEs were really doing some work around maternal health. And so with the sub-state implementation comes a comparison region. And so because we're going with the sub-state implementation, a part of the state will have to serve as control for the counties that we've selected. And so next slide, please. I'll show you how that kind of maps out. Okay. So these are the counties that we're going to be working with, or the counties that we've proposed to CMS. Thank you, Barbara. I always feel like everyone knows the acronyms, MCEs and whatever. So thank you for dropping that in the chat. So these are the counties that we want to focus on. And like I said, we were very deliberate in picking the counties because we looked at our Medicaid data. We looked at where most births were occurring in the state. And we also looked for where we had access issues. And so we settled on these counties as well as some zip codes in Tulsa. And the zip codes in Tulsa was because it's an area of North Tulsa where they have high infant mortality. And so they felt like we could bring some dollars into that area to do some good work with the moms and the babies that would be born. When we were negotiating with CMS wanted Oklahoma County. So originally we had included some zip codes in Oklahoma County, but CMS wanted Oklahoma County to be a control county. However, we had been having conversations with the Oklahoma City Indian Health Clinic, and they were really excited to be a part of this when we talked to them about it. And so we went back to CMS and said, even if you don't want us to implement in Oklahoma County, can we have one site? Since the ITU providers were a call out for them as well. They wanted us to do a lot of work with and ITU means IHS, tribal, and urban Indian clinics. So we asked if we could make an exception for the Oklahoma City Indian Clinic. And so we don't know yet if we're going to get that approval, but that's something we put out there for them to consider. Next slide, please. And so I don't know if everyone can see this, but essentially this is our work plan. One of the things that CMS told us that we could not do was to duplicate services. And so if that service was already taking place in the state or was already, going on in the state, we couldn't take CMS dollars or federal government dollars and try to replicate those services. And so this meant that we had to be innovative in our thinking of how we were going to implement this. And as we thought through it, we did find several other entities who were doing some of the work that we would need to do with the TAMR grant. And so what we did was to basically, pull them into the work group meetings and just propose what we were thinking to them. So first off, our managed care entities have to be involved. We need buy-in from providers. We've kind of started looking at the providers that deliver most Medicaid moms, most Medicaid babies in those counties. And we're going to be reaching out to them and having, conversations with them and trying to recruit them to be a part of this. Another partner that we have in this is the Oklahoma Primary Healthcare Improvement Collaborative, and they're under OUHSC, and they're under Dr. Crawford used to be the PI over that. And they do a lot of practice facilitation work. And there is a piece of this that has to do with practice facilitators going into the clinic and helping the clinics to do a better job of screening and documenting and referral and closing the feedback loop and all of that. And then there's a doula piece of this, which we've told CMS that we would like to contract with OPQIC OPBEI. They used to be known as TBEI. Um, to recruit doulas that will stay within those communities for us, as well as we are working with a tribal doula who would focus on recruiting tribal doulas for us in these communities that we've identified as our test region. And then we do have a partnership currently with the health department that links Medicaid data to vital records. And that allows us to see, our babies and, where they're born and all of that. That's another thing that CMS wanted us to really, put a lot of emphasis on, to link Medicaid data to other sources so that we're having a more complete picture of, Medicaid pregnancies. And then we talked to Lori's group back then about, leveraging the pregnancy, and Kelly as well, leveraging the pregnancy resource navigator program, the perinatal community health workers, to help us do some of this work, because it was one of the provider types that CMS was wanting the Medicaid agencies to really work with. And one of the things they had even requested was to see how we as a Medicaid agency could make that a provider type. And that's something we're still kind of working through, but we're circulating it, amongst our leadership. And of course, with OPQIC, they wanted us to really partner with our perinatal collaboratives to, work on the AIM bundles and all of that. So we have several partners, and over the next couple of months, we're going to be meeting with our partners and kind of mapping out the scope of work that we're going to eventually carry out starting year 4. Next slide, please. Okay, so our next steps. So this actually, the award was made December 19, but CMS kind of put an embargo on it to where we couldn't even tell our partners that we had been awarded until they made a public announcement, I think January 6th. But officially, work started on this January 1st or January 2nd when we got back to work. Right now, we're in the process of, like I said, the first 3 years are planning years. We're in the process of going back in to our proposal and kind of building out our regional plan. So we have to pull data, we have to pull those comparison counties, we have to line them side by side. If there's anything we left out during the proposal stage, we have to build all of that in and I guess come up with a more comprehensive regional plan that can actually be operationalized. So that's one thing they've asked us to do, and that's due by the end of February. We're also supposed to start defining the scope of contract of work that our contractors will do. And so that's in February. We're going to be pulling, OPQIC, OFIC, all of them into meetings and kind of walking through what the scope of work will look like for them and mapping out their budgets as well. We're currently in the process of setting up meetings with CMS. CMS has contracted with Mathematica to do the technical assistance piece of the model implementation for them. And so every state has a coaching team. And so we get to meet with our coaching team sometime in March and then set up meetings and they're going to help us develop a work plan. And then I think we also have to come up with a health equity plan for maternal health, but more to come on that because we haven't really met with them. And then, of course, we continue to, coordinate with our stakeholders and just reach out. We're in the process of creating one pages that are simple to understand, tells you what TIMA is, tells you what your part is as a midwife, as a birth center, as a provider, and all of those. So that we're in the process of doing some of that work. I think this is my last slide. Yeah. And so I know that's a really high level overview. It goes more in depth. If you would like me to send you the proposal or if there's any questions that you have, I'll be happy to answer them. And then I'll also put my email in the chat.
Thank you so much, Falaki. We look forward to working with our partners at OHCA on this transforming maternal health partnership and the work that we'll be doing. So we're very fortunate here in Oklahoma that we all have a good relationship with our Medicaid agency and that we all get along. The state agencies, where many states don't have that situation and it can be challenging. So we thank you for your leadership, Falaki, and for your partnership.
I mean, thank you all for the work you do. Like, we take a cue from you all. So,
Yes, well, we appreciate your support because over half the births in Oklahoma are covered by Medicaid. So it's very important work.
I did have a quick question, Barbara.
Uh-huh.
Balaki, I'm curious, in the plans you've done so far or in the ones coming up, I saw screening included for substance use disorder. Have you, and because Barbara's been so involved in the work with family care plans and plans of safe care, is that woven in any way to the whole person care?
so we have meetings with Barbara's team to kind of talk about the overlap and where we can, align things. And so when we wrote the proposal, we were very high level. We just said we have a great partnership with our perinatal collaborative. We will be working with them. But now that they've given us the grant, they're asking us for more information. So we're going to have to start meeting and talking about that part and trying to see how we can align those things.
But yes, Terry, we will certainly weave that in. Thank you for bringing it up. Any other questions? Thank you so much, Falaki. We'll talk with you soon. Next, we are going to share some legislative agenda items for OHA that Scott Toline will be sharing. And Denise has got the slides up. So Scott is the VP of Advocacy at the Oklahoma Hospital Association, and we're thankful to have him here tonight to talk about a few legislative items that we'll be looking at and focusing on for the upcoming session.
Hey everyone, hope everyone's having a good evening. Thank you for letting me interrupt your meeting just to give a brief update of what OHA is pursuing this year at the state legislature. That doesn't mean that we don't support other pieces of legislation that may not be on our legislative agenda, but there are bills that we do request that are important to our member hospitals and facilities. And so one of those bills that has been an item of discussion at 23rd and Lincoln is the 340B drug pricing program. Not sure who all might be familiar with that, but it is a federal program that does not concern tax dollars, whether it be federal or state. It is an agreement between a drug manufacturer and a contracted entity, namely a hospital, an FQHC, our state health department utilizes 340B, etc. But they enter into an agreement to sell certain medications at a reduced cost to our contracted entities. Well, over the years, the drug manufacturers have been putting on some parameters on how they will agree to participate in the 340B drug program. Those are outside of what federal laws, federal rule and regs permit. And unfortunately, I don't see Congress moving quickly at all to somehow solve this crisis in DC. So because of that, we have seen a number of states, I believe 7 in total so far, that have passed legislation that isn't anything novel. It just simply says that you, as the drug manufacturers, have to abide by federal rules and regs as it relates to this program. So that's 340B. We can skip these. These are just making our case. The slides that you see here are slides that we at OHA travel around the state in January to visit with our hospital members, our CEOs, and then local lawmakers. And so this is what we have pulled this from. This map, I think, probably makes our case the best when it comes to 340B and protecting it from drug manufacturer manipulation. So you can see from this map, every single entity that participates in the 340B drug program, and as you can see, it touches pretty much every county in the state. And this is hospitals, clinics, FQHCs, and others that participate in the program. And if you are not familiar with it, it just really allows these contracted entities to stretch scarce resources to their communities. I often like to hold up a Southwest Cancer Center in Southwest Oklahoma. That Cancer Center was stood up on 340B savings. And so folks are able to remain in their communities and not travel up the highway to Oklahoma City or go down to Dallas to receive the care that they need, and they can remain local. Next. Sooner Select prior authorizations. So last year we passed a bill, House Bill 3190, that really updated the prior authorization process. And in some ways, it really mirrored final rules that came out of CMS as it relates to prior auths. At that time that we passed this bill, we did not include our Medicaid managed care program, Sooner Select, in that bill because Sooner Select had its own prior authorization requirements. And so we wanted to give it time to see how those prior authorization requirements were playing out. In the real world, they're not playing out well from what was put in the statute in 2022. And so we are amending this bill that we passed last year regarding prior auths to include Sooner Select. And what it really does, layman's terms, it stretches out the amount of time that we have to get those documents and materials to the contracted entities with the state for prior authorization. I will let Emily Kopic talk about sepsis. You're on mute.
Yeah. Emily, will you introduce yourself before you
Yes,
start here?
that's what I was trying to do. And like Falake said, you'd think I'd have this figured out by now, but you know, I'm off mute on my phone and need to be off mute on my computer. But my name's Emily Kopic. I'm the Vice President of Clinical Excellence for the Oklahoma Hospital Association, and I'm a nurse by background, actually an IC nurse by background. And so when we were approached by some of our hospitals regarding some sepsis legislation, I jumped all over that with Scott and Maggie and was excited to be able to dive into this with them. And so what we're trying to do with this bill is, for those of you that may not be aware, in 2016, the coding definition changed for sepsis, where it made it your patient had to have end organ failure or require ICU level care in order to be diagnosed with sepsis and not receive denials from payers. And so all of us know that are in clinical on the call know that time is tissue when you're working with sepsis patients, and that our hospitals necessarily didn't stop treating patients for sepsis. In fact, we have strived to do better and better to meet the Step 1 bundle for CMS, but also to ensure that the patients are cared for in a timely manner. We know that mortality increases 4 to 9% with every hour delay in treating sepsis. And so hospitals have still continued to do that early goal-directed therapy, but unfortunately, if that patient did not require, or fortunately, if they did not require ICU level care, we could not diagnose that patient with sepsis. And so this bill is ensuring that every hospital has those protocols in place. And so where we thought it'd be special to bring it to you all today is that that also includes those special populations. So pediatric patients, the maternal health patients, you know, we know that they have different criteria for meeting sepsis definitions and sepsis protocols. And so we want to make sure that our state is moving towards having protocols for those special populations as well as the adult population. And then this bill would also help us in being paid for the care that we're providing. And so this would require payers to utilize the sepsis 2 definition, which is that SIRS criteria and a source of infection, to allow us to diagnose our patients with sepsis. This would be the way that we could make sure that those patients that come in meeting that criteria, that we're providing that care to already, that we're getting reimbursed for those services. So any questions regarding this bill? All right, thank you so much.
So these are some of the bills that OHA has requested on behalf of the association, our members, but obviously for many of you in this space, there are a number of other bills that have been filed. Some that might be of interest to you all. Senate Bill 1058. This would require perinatal mental health screenings anytime a healthcare provider sees, and tell me if you talked about any of this. I will not mention it. I see heads nodding. No? Okay, great. Require providers to conduct such screenings if they see a mother and an infant at any time during the perinatal period. House Bill 2915 is a maternal mortality review committee update. I'm going to classify it as an update because what it does is it permits that committee to have create additional advisory committees under it and then assign members to it. Those are both sponsored by Democrats. I don't know how much, what's the word I'm looking for?
Traction or support?
Yes, thank you. Traction. I've been traveling a lot today. Sorry. A lot of traction. I don't know if they will get a lot of traction. Now, one of these members, I think, does a really good job on the bipartisan piece of things, so they probably have a more of an opportunity to get something passed than others. Senate Bill 222, that bill creates a $5 million pilot project to bring OB services back to rural Oklahoma. I will tell you, it is a request of one of our member hospitals at OHA, in particular, Shattuck, Oklahoma. They have been working with their state senator and the budget chairman in both the House and the Senate to restand OB back up out in Western Oklahoma and in Shattuck. So I see that getting some movement as long as this overall state budget picture will allow it. And then there are always a number of other bills related to vaccines that have been filed. There's one regarding informed consent before a vaccine is given to an infant. I'm trying to think about, let me pull it up real fast. I want to... Yeah, it doesn't specify. Oh, Hep B. You've got to get a parental consent to provide a Hep B vaccine. And then also probably of note for this group, there are a number of APRN prescriptive authority bills that have been filed this session again. So that is a conversation that will continue at 23rd and Lincoln that has very much dominated a lot of the healthcare conversations the last several years at the state capitol. But that is all I have. I'm happy to hang out for a minute to answer any questions if anybody has anything.
Scott, what is the bill number for the Shattuck?
Senate Bill 222.
Okay, thanks. And we will, the session starts February 3rd, and we have another meeting April 15th. So that's easy to remember on tax day. We'll provide an update. Who knows what will be happening at that point, but that's when we focus a little more on the legislative agenda because we generally have, can identify what's happening and what's moving forward and things like that. If we have any other bills during the session also that we need your attention, we will reach out. So thank you so much, Scott. We appreciate that. And thank you, Emily. I want to keep you all up to date and aware of what's going on at the Capitol as they begin their work.
Thanks.
Thanks so much. I want to turn now to the Maternal Mortality Review Committee report that the state released this fall. And here is the link to that. It can be found on the Oklahoma State Department of Health website and our website. Here, you can also scan this QR code. So I'm going to go over some of the information that's in this report, but I would encourage each of you to read it on your own. So just some definitions because this can get confusing. Maternal mortality, when we use those words, that's the death of a woman either while pregnant or within 42 days of termination of the pregnancy from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. This is the definition that is used when we are defining rates at the national level and for different countries when we're comparing the United States to other countries. So when you hear maternal mortality rate, that is the 42-day definition, and it is related to pregnancy. The pregnancy-related deaths, these are deaths of a woman while pregnant or within 1 year of the termination of pregnancy. And this is also irrespective of the duration and site from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. This is the rate used in the United States in Oklahoma for reporting purposes. The denominator for all of these, I should emphasize, is per 100,000 live births. But the key here is the last two definitions are those that are used from state maternal mortality review committees, and these are deaths that have been reviewed by the committees. Because we have to determine during that review whether this pregnancy was related, and you get a lot of postpartum ones that may be harder to identify via death certificates. So these are pregnancy-related deaths go out to 1 year, and then pregnancy associated also have the 1 year time period, but it's from any cause. So this does not have to be related to pregnancy. This could be, for example, someone who dies in a car crash who had been pregnant 6 months prior. So that would be considered a pregnancy-associated death. And again, this is the 100,000 per 100,000 live births, and this is a definition associated with the timing of the death. So next slide. This is from the March of Dimes report card that was released in November. You will see data here that is national rates. On the right, you see the different rates per 100,000 live births. This is maternal mortality. So these are those that are obtained by death certificates, and they are this is the 42-day definition. You can see the increase during the COVID-19 pandemic, particularly in 2021 with the Delta wave that impacted pregnant people so much, pregnant and postpartum, and then started going back down in 2022. And then you see on the left side, the bar graph shows deaths per 100,000 live births by race and ethnicity for 2018 and through 2022. So they combine the years in this graph here. So you can see the disparities that are dramatic here with the American Indian Alaska Native at 58, Black at 51, and Pacific Islanders at 47.4. And then the white, Hispanic, and Asian have a much lower maternal mortality rate. If you look at the next slide, the Healthy People 2030 goal was 15.7. So in Oklahoma, for maternal mortality rate and all of these data, we have to group years together because our numbers are relatively low. So for 2020 through 2022, our rate for maternal deaths within 42 days of termination was 31.9 per 100,000 live births. And you saw the previous slide, the United States rate, it's a different time period, only for 1 year, but it was 22.3. Any year that includes that 2021 in it is going to be higher. So, but we do have to group the years together because our numbers are so low. So our source for these data is the Oklahoma Vital Records. And here we have the 3-year maternal mortality rate, excluding and including COVID-related deaths. You can see the impact of COVID on maternal deaths. The dotted lines are those that include those that have COVID-related death and in it, and the solid lines exclude the COVID-related deaths. So our numbers have been going down since the 2017 time period. If you look at that in Oklahoma, and if we exclude those that are related to COVID. Next slide. These are data now that I'm speaking of that come for those that have been reviewed by the Maternal Mortality Review Committee in Oklahoma. So these are deaths that occurred between 2017 and 2021 that have been reviewed by the committee. The age range of the decedents are 15 to 42 years. 26.3% or 21 were of an advanced maternal age, which is defined as greater than 35 years. 61.5% we say experience poverty. We use Medicaid coverage as a way to identify that. And that 61.5% is compared to about 52% of our births are covered by Medicaid. 42 deaths were identified as, or 52.5, so a little over half, were identified as related to pregnancy. And sometimes we may not have enough information to determine that, so it can be unknown, or some are determined not related to the pregnancy or pregnancy associated. The top causes among those that are pregnancy related with an MMRC determination of cause of death, that's 40 cases there. We can see it nicely divided into quarters. 25% were cardiac conditions, infections for another 10, 25%, another 10 were related to hemorrhage, and then other was another cause. And I'll break that down a little bit more in another slide. So these are deaths by age. The green line are the MMRC reviewed deaths during those years. And the peach line is the birth. So just to be able to compare if there is an age that is overrepresented in deaths. So you can see the two ages at the end of this scale, less than 20 or greater than 35 years, are overrepresented in deaths. They had 26.3% of the deaths, while only 12% of the births for those that are 35 and up, and those that are less than 20 have 10% of the deaths and only 7.1% of the births. The others are underrepresented in the deaths. They have a lower percentage of deaths than they did of births. So these two extremes in the age ranges have a higher contributing the age contributes higher than the other age ranges. And these are timing of death. You can see 32, or about a third, are pregnant at the time of the death. 16.3% passed away on the day of delivery. 20% 1 to 6 days after the termination of the pregnancy. 20% at 7 to 42 days, and then 11.3% at that 43 to 365 days after the termination of pregnancy. So that 11.3% would not have been included in the maternal mortality review committee. I'm sorry, the maternal mortality rate of the 42 days. Sorry. Place of death, a little over half were inpatient, about 20% in the emergency room or outpatient, 17.5% in the decedent's home, and 6.3% were in another location. And then looking at it, ask about substance use disorder, if that contributed. We were able to identify yes or probably for 11.3% of the cases, or 9 cases. No in 43 or 53.8% of the cases. And then for 28 cases, or 35%, it was unknown or missing, or we could not determine from the information that we had. And then this slide here, we talk about whether the death was prevented, is another decision, preventable, that we make as a committee. So it was determined of those pregnancy-related deaths, 78% were preventable. So the majority, if something had been done differently at the patient level, or maybe at the hospital level, the community level, the system level, if something had been different, that death could have been prevented. 14.6% were determined not preventable, and 7.3% we were unable to determine. And of those deaths, then also it asked, was there a chance to alter the outcome? If there was a chance, was this a good chance? So that was determined in about a third of the cases, 31.7%. Was there some chance in 43, and that was determined in 43.9%, or no chance or unable to determine was in 24.4%. So if the death was preventable, then we have to determine what was the chance to alter the outcome. Next slide. This, I don't know if you can, hard to see, but this breaks down those the inner circle goes into the 25%, the different quarters of the contributing factors of the pregnancy-related deaths, and then it breaks them down into a little bit more detail. So you can see on the infection, for example, 30% of those were related to COVID-19, 40% had sepsis, and 30% had others. And with hemorrhage, 40% had ruptured ectopic pregnancy, 30% had a postpartum hemorrhage, and a different type of hemorrhage was for 30%. For the other category, 30% had an amniotic fluid embolism, 30% had hypertensive disorder of pregnancy, 20% a thrombotic embolism, and 20% was unknown. And then the other 25% cardiac conditions, 50% of those were cardiomyopathy, and 50% were another different cardiovascular condition. So I think that's the last slide for the MMRC report. I would encourage all of y'all to read it. We do have changes this year with our committee. Scott mentioned a bill this year that is going to be introduced. Who knows what will happen with it, where we could have different subcommittees of people that had different areas of expertise that might be particularly needed this year because they've reduced the size of our committee by statute to, I think there's only 11 members now, where we had over 20 members, lots of different types of people that had lots of various expertise, and now the size is decreased. So we may have more need for different people to be involved in reviewing some cases. So we have a few other updates. First, before I go on, are there any questions about the Maternal Mortality Review Committee report?
Hey, Barbara, this is Em. I think one other thing we should talk about is that MMRC report and how it's going to be important for the hospital obstetrical departments coming forward in the next couple of years when they have to meet those new condition of participation. And so for those of you that are on the call that may be over the department at a hospital level, you'll be needing to incorporate some of that MMRC level data into your department level quality assessment performance improvement projects. So more to come on that.
Yes, and we do for OPQIC, we certainly use those. We use the report to guide what we do. And so, but it's important for you also at the hospital level to look at the report. And also if you do have a death, to certainly review it at the hospital level, because we don't even know where these take place. This is all the MMRC serves to prevent future deaths. We don't know any information about where they occur or anything. So it's important for you all to definitely do a good review of these deaths to see if there are changes that can be made that could have prevented that. Also, to remind you, they are now required to be reported to the medical examiner's office. Thanks, Emily, for highlighting that. Okay, we have a couple more updates and then we will be finished for the evening. Katie has a couple of teen birth updates.
So just an update on teen birth. We are currently in cohort 5. So at our last quarterly meeting, we told you that Weatherford Regional Hospital and Great Plains Regional Medical Center both launched teen birth. Since that meeting, we have had Claremore Indian Hospital and Integris Health Southwest Medical Center have launched their teen birth. And there's pictures of both of those. They were very well attended and wonderful celebrations of that. And then launching here in 2025 at the beginning of the year, we'll be having Choctaw Nation, Integris Health Woodward, and Lakeside Women's Hospital. So we'll have pictures of those hopefully at our next quarterly meeting.
Thank you. Exciting. These launches are always fun. So thanks so much, Katie. And Melissa wanted to give an update on low-dose aspirin and pregnancy.
Hi, everybody. So I know you've heard about this initiative in the last couple calls that we have done. If you are new to joining us, however, our low-dose aspirin in pregnancy initiative launched in October of 2023, and it was launched in effort to reduce rates of prematurity and preeclampsia in Oklahoma. Unfortunately, Oklahoma has ranked very high in the past for prematurity. And we were happy to see that in 2023, our prematurity rate dropped from 11.3 in 2022 to 11% in 2023. So that's the best we've actually been since 2016. So, and no doubt to a lot of effort from various groups that have really worked to address women and infant health in Oklahoma. And preliminary data that we have from the Oklahoma Healthcare Authority has indicated that we've seen a drop in some of our eclampsia cases in 2024 that are really promising numbers, because it kind of indicates to us that, you know, even though some women may still be getting preeclampsia, it's not as severe. If you don't know what eclampsia, it is when you get seizures during pregnancy. So that was exciting to kind of see some of that. More data to come. Of course, we're still waiting from final data from Sooner Care. It can take up to 6 months to get that. So in the time since our last call, I've presented to a few more groups, including chapter members in A1 Central and North Central Oklahoma. And then in December, I presented to the Oklahoma Pharmacists Association, the live CE event. We know that it's not just the work of those that work in the hospital systems or in the clinics that can really make a difference when it comes to encouraging patients to be adherent to low-dose aspirin. It takes a village. And so pharmacists are great because they are the most accessible caregivers in a lot of our communities. And we know if patients have questions, they can always go to a pharmacist for that. In the meantime, also, I've been working on a change package with the California Maternal Quality Care Collaborative. Really exciting work coming out of them. I know I mentioned before that some elements of our toolkit were included in the Million Hearts campaign that has been put out from the American Heart Association. And just if you are interested in some of the materials that are included in those toolkits, you can always access them at our website at any time. And I'm still able to send you pre-printed materials from that toolkit as long as you just email me and ask for it. An update on our social media campaign. We've been fortunate to have funding from the George Kaiser Family Foundation to support this. And not only have we been promoting things like low-dose aspirin in pregnancy, but also addressing medical marijuana use in pregnancy, healthy, safe sleep habits. But so far with our social media campaign, we've reached over 3.7 million impressions. So that's huge. It's really exciting to see. Impressions means that it's come across a person's feed. In this case, probably more than once, because the population that's been identified is women between the ages of 18 and 50 in Oklahoma. And I just wanted to highlight our November social media post that went out in light of Prematurity Awareness Month. We were very fortunate to have an Oklahoma mother share her experience getting preeclampsia and giving birth to her daughter at 29 weeks. And I think it's important to note that the only risk factor that she had was it was the first time she was ever having a baby. Nulliparity is a moderate risk factor. And so that just goes to show you that preeclampsia can strike anyone. There are some people that have more risk factors than others. Our estimate is that about 70% of Oklahomans who are pregnant could benefit from taking low-dose aspirin. So what's next with this campaign? Well, we are going into American Heart Month next month, tongue twister. In light of that, we want to make women in Oklahoma aware that when you get preeclampsia, you always need to be on high alert afterwards, because about 20% of women still have persistent hypertension after a preeclampsia diagnosis, and about 50% will be diagnosed with hypertension in the next 14 years after a pregnancy. And of course, in Oklahoma, heart disease is the leading cause of death in women. And then what's next also is that we want to focus on additional drivers of maternal and infant health in Oklahoma. So I mentioned marijuana use in pregnancy. There was a study that just came out that found that marijuana use has significantly increased in the population. And in addition to that, also other substance use disorders in pregnancy. And along on that note, addressing STIs, especially congenital syphilis, as we see those rates rise in Oklahoma. Marijuana use and STIs can also increase the risk of having a premature birth. So that is all on the low dose aspirin and pregnancy front. Thank you.
Thank you so much, Melissa. Becca asked if you would share those studies. So
yes, I will be sending outputs from this meeting sometime in the next day or two. And so I will include those studies.
Thank you. Okay. Next slide. Evelyn was going to remind everyone about the maternal mental health hotline. This is so important that we want everyone to know about this. So Evelyn.
As Barbara mentioned, just some reminders about the maternal mental health hotline. Talk about another tongue twister. And I'm very excited about the House Bill 1058. And so remembering that as you are doing your screening, that this is a resource. If you have no other resource, at least utilize the resource of the hotline. And as well, the ACOG perinatal mental health toolkit is available, and you can access that there at the link on the bottom, and has all kinds of information on screening and how to treat patients, educational resources for providers. So this is a great tool to utilize in the clinic space, and then making sure we're sharing those hotline information everywhere, hospital, clinic, anywhere that a pregnant patient may present, because you just never know. And they're not always very forthcoming with information as far as wanting to share that they are struggling. So sometimes just having those handouts and tools available for the patients, then they might trigger them to reach out for help. So thank you very much.
Thanks, Evelyn. Any questions or other business that our participants might have? Well, we appreciate your joining us this evening. Next meeting is on April 15th, as I mentioned, on tax day, and then July 15th. So if you'd like to get to register to be added to all of the quarterly meetings, you can go to our website here at this link to get the recurring invite, or just register for one meeting. So thank you all. We hope to see you again in April. If you have any ideas for topics that you'd like us to include, please let us know. And I'll let Denise share our upcoming events.
So just a couple of events we wanted to make sure that everyone was aware of. On January 30th, so next week, we do have two of our own that are going to be presenting at a webinar. Emily Kopic, she spoke earlier about the CMS conditions of participation. So there have been some updates that apply to a lot of hospitals that provide obstetric services, and as well as those that have emergency services regarding emergency obstetric readiness. Emily, along with Katie Morgan, are going to be presenting at that webinar next week. And then Oklahoma Perinatal Nurses Forum has our perinatal nursing boot camp. And this is a course that is designed for nurses who are new to the perinatal space. That is going to be occurring on February 25th, 26th, 27th, and March 6th and 7th. So if you have not registered yet, new employees or new staff or nursing staff that you have new to that space, then feel free to go to the OPQIC website and look for the OPNF bootcamp page. Thanks again to everyone who is in attendance tonight. We do appreciate your support and your partnership.